Hi, everyone. My name is Anne-Marie Hayes. I'm a research associate for the Joplin campus of KCU. Today, I'm going to be introducing our speaker, student Dr. Taylor Reardon. Student Dr. Reardon is coming and presenting to us through NERV, which is a neuroscience virtual interest group, which is a national organization that we at the MKRC pair with to provide presentation opportunities and allow KCU students to connect with this national organization. Usually student doctors who are interested in neuro-related specialties join the club. So if you have any questions about NERV, feel free to email me. Or on the flyers that go out, there's usually a link to the NERV page that we host on our MKRC Canvas page. I can also drop that in the chat once we get started. Just so you know, though, if you're coming to us outside of KCU, you probably won't be able to access the link because it is our intranet. It's KCU only allowed on our Canvas pages, just so y'all are aware. I'll also throw the YouTube link in the chat, though, where we host all of our presentation videos. So you won't be missing anything because I'm hosting the same thing on the Canvas page. It's just our past and future presentations. So on YouTube, you'll be able to see all of the past presentations that we've done. This is also our second to last journal club of this semester. So we have one more next week, and it's actually on Tuesday at noon. So it's reflecting our time change. We're looking at moving the series to Tuesdays at noon. So I hope you'll join us for our very last one next week as well. It's going to be a student doctor from KCU presenting, and then I'll send out an announcement as well for all of that. So without further ado, I will introduce our speaker and we'll get going. Student Dr. Taylor Reardon is a fourth-year medical student at Kentucky College of Osteopathic Medicine and currently serves as a senior director for the Neurosurgery Virtual Education and Research Group, which is also the acronym NERV. Taylor plans to specialize in neurosurgery following medical school, and his research interests include surgical management of craniectomy, minimally invasive spine, and medical education. So with that, the floor is yours, Student Dr. Reardon.
Thank you so much. So yeah, like she said, my name is Taylor Reardon. I'm a fourth-year medical student at KCOM, and today I have the pleasure of discussing an article that I was fortunate enough to contribute to this past year. It's titled "Management of Lambdoid Craniosynostosis: A Comprehensive and Systematic Review." This was a joint effort by myself and some other physicians and residents from California, Tufts in Boston, University of Kentucky, and Northwestern. Let me get my slides here. Okay, so then just to start off, I'm just going to give a little overview of the talk. We're going to talk kind of about what craniosynostosis is and specifically what it means when it's a part of the lambdoid suture. Some of the more common operative techniques that are involved in the management of this condition, and also discussion of the systematic review that was conducted to investigate the statistics behind the operative management of this condition. So to start off with, just talking about craniosynostosis in general, it's basically the premature fusion of one of the sutures that are on the skull when a baby is born. And starting out there, I like this figure here from Brown Neurosurgery that kind of puts the normal skull in the middle there, as you can see, and kind of highlights all the different sutures that you have and will notice on a child, the metopic, coronal, sagittal, and lambdoid. And then around the clock kind of shows all the different possible types of craniosynostosis that can occur. And the one that we're going to be talking about today is kind of at that 3 o'clock position, that posterior plagiocephaly or lambdoid. And as you can see, there's many different types. So there's metopic at about the 11 o'clock. There's a synostotic scaphocephaly, which scaph also means boat. So you can kind of see the head's kind of a boat shape. There's a deformational posterior plagiocephaly at about the 5 o'clock position, which is very similar to lambdoid, that we'll kind of discuss the differences of those and how to notice those in a clinical setting. And then also at about the 7 o'clock is unicoronal and a bicoronal synostosis. So just a background on the condition, the first documented case of lambdoid craniosynostosis was actually found in a fossil at about that was dated at about 530,000 years old. So this is not a very new condition by any means. And this, like I said, was a premature fusion of a suture, depending on which one it is. This condition can be categorized as syndromic or non-syndromic, and the non-syndromic ones have a stronger association with only closures of one suture versus your syndromic ones have closures of multiple sutures in addition to systemic conditions as well. The incidence of the condition in general is about 1 in 2,500 live births, and the severity of it can vary. And specifically, lambdoid craniosynostosis prevalence is 1 to 4% of all of the craniosynostoses, which makes it the rarest of all types. So it occurs in 1 in 2,500 births, and then 1 to 4% of those is lambdoid. So it's not a very common condition, but it still occurs. So the symptomatology of these patients can widely vary. You can have a patient where you just notice the physical appearance of their head and it's detected later on imaging, or sometimes if it's super severe, they can display symptoms such as increased intracranial pressure, which can have its own sequelae, hydrocephalus, neurodevelopmental delays, a lot of neurologic deficits, respiratory deficits due to the increased intracranial pressure, and can even be associated with Chiari malformations. There have also been multiple studies done by neuropsychiatrists that have shown that not only are there short-term outcomes of this condition, but there's also long-term neurodevelopmental outcomes for these children. So there were multiple cohorts that were analyzed that showed that children with craniosynostosis developed increased snoring, sleep problems, language, learning, and memory issues. And also, while there was not a statistically significant difference in the attention and executive function of these children, there was a positive trend. So you can see that if this condition is not corrected and detected early on, it can lead to a lot of issues. And while there's no one mechanism that is identified, proposed reasons why this happens is just the increased pressure inside the head can cause just decreased blood flow to these areas that are in charge of these functions, or even mechanical deformation. So the actual brain that is pressing up against the skull on the side of the fused suture is leading to decreased functioning in these areas. So there's multiple different syndromic craniosynostoses, and I could be here all night talking about them, but I'm only going to highlight 3 of the most common ones that are associated with lambdoid craniosynostosis. The first one is Crouzon syndrome, which has autosomal dominance inheritance of about 1 in 25,000 live births. It's more commonly associated with a coronal synostosis, but also it has the highest incidence of lambdoid involvement. And is also characterized by mid-face hypoplasia, exophthalmos, or bulging of the eyes, as you can see, and hypertelorism and Chiari malformations. FGFR2 and the FGFR family has a large play in the development of this syndrome. So you'll be seeing that pop up a lot with this. And then there's also kind of a subset of syndromes that is associated with acanthosis nigricans that has a mutation in FGFR3 as opposed to FGFR2. Second is Sapphire Chosen syndrome, which is also an autosomal dominant inheritance. And while this one has a lot of face changes, as you can see, there's also a lot of limb abnormalities and also involvement with the eyes with ptosis, small ears, and prominent crura. And this also has a loss of function mutation in twist and is also associated with FGFR2. And finally, the rarest one is Antleigh Bixler syndrome. There's very few case reports on this, but it does occur. It's an autosomal recessive inheritance. And while this one also has interplay between the development of the face and the limbs, it has more systemic involvement, such as renal malformations, gynecologic malformations, syndactyly and arachnodactyly. And as it shows here, FGFR2 has a large play and also POR mutations. So earlier I talked about I guess the more clinical application of this information is determining positional plagiocephaly versus lambdoid craniosynostosis, because a lot of times when you leave a baby on its back for a long time, it can kind of mold the skull sometimes, and parents come to you really concerned saying, what's going on with my child? Why does my child have, this really weird shaped head? And it's your job sometimes as the physician to be able to differentiate whether the child just needs to be rotated on its side or if this is actually something that needs to be intervened on surgically. And one of the more common ones associated with this condition is positional plagiocephaly versus a true lambdoid synostosis. And so there's 4 tenets that are usually driven in determining the difference between the two. One is just the overall shape of the head. So when you have a positional plagiocephaly, their head's going to be shaped more like a parallelogram versus a trapezoid shape. And I have a nice chart on the next slide that'll kind of highlight these things. Second, looking at the side of the synostosis, you want to look at the ear and you want to look at how it moves. So in a positional plagiocephaly, the ear will be displaced anteriorly on the side of the synostosis versus you'll have a pull down inferiorly if it's true craniosynostosis. Thirdly, you'll look at the occipitoparietal contour where you'll have a flattened versus a bossed effect. And then finally, one of the more telltale signs is the frontal contour. Whereas on a positional plagiocephaly, you're going to have ipsilateral bossing or a protrusion of the skull on the side of the proposed craniosynostosis versus in a true lambdoid, you're going to have contralateral bossing of the frontal contour. So really taking all those into account will allow you to kind of narrow down your diagnosis a lot easier. And the mechanism for this was kind of proposed by Virchow. He has a lot of different things in medicine. It was proposed a long time ago, about 200 years ago. And the reason why this happens is really the growth of the skull is restricted perpendicular to the fused sutures, which makes sense. And when you take a force vector and apply it to a fixed space, it can't go past it. So you're going to have it spread out in multiple directions. So this is kind of the graph that was in the paper, and it kind of demonstrates the differences that you would observe in a patient with posterior or positional plagiocephaly versus lambdoid, looking at a posterior, oblique, anterior, and lateral view. And as you can see in the bottom, in the posterior view, you can see that the craniosynostosis is on the right side, right posterior side, and you can see that ipsilateral inferior ear displacement versus anterior with the plagiocephaly. So this is a chart that when I rotated with pediatrics, I was able to carry around. And while I didn't really see one like this, it's definitely a useful tool in the clinical setting. So now that we've found a potentially a lambdoid craniosynostosis patient that needs an operation, when do you operate? And unfortunately, it's not a black and white decision. It's a very gray area that is controversial in the literature. So it's been mostly separated between 2 to 6 months at the time of diagnosis, the age of the patient, and 6 to 12 months. So 2 to 6 months, what has been found in literature is endoscopic suturectomy. The reason why this is mainly used at this time is that the bones of the child are more malleable at this time and allows for better reconstruction of the cranial base, which, as you know, has a lot of different and important structures coming out of it and passing through it. However, there is a higher risk of anesthesia in a patient aged 2 to 6 months and increases the duration of a postoperative helmet orthotic that needs to be worn, which means that you need to have a lot of trust in the family that brings their child to you and make sure that they follow up appropriately. Following this, there is the 6 to 12 month age. Now, this is sometimes preferred because there's more optimal cosmesis via allowing full reconstruction of the skull. The skull is pretty much hardened at this time. However, because of this and because of the increased blood flow through the bone, there's increased bleeding. And at this age, 100 ml blood loss can be very bad for a child. And also it can sometimes have decreased manipulation of the bone. It's not malleable, it's hard. You have to use a drill or something like that to shape it the way you want it. So just discussing, I won't go into super large detail about all the different types, but these are the most common ones. So for the younger children, the strip craniectomy, or sometimes called a suturectomy, it was the first technique utilized. And over time, it was transitioned to an endoscopic approach with the utilization of the postoperative molding helmet. And like I mentioned before, adherence and follow-up after the surgery is critical to make sure that the surgery does what it was supposed to do, and also the helmet is doing what it's supposed to do. There's limited scarring, and sometimes there have been controversial results even with the postoperative molding in comparison to an open vault reconstruction at this age, which is why the time to intervene on these children is still controversial. And then just talking about the postoperative helmet, I'm sure you've all seen a young child that's had one of these protective helmets on at some point. It's usually introduced on post-op day 5. And the goal of these, it's not just a helmet that you place on. There are some sides of it that are made so that the growth is restricted in those dimensions, so that you allow for expansion of the suture that you just released with the suturectomy, but do not allow growth on the sides that are commonly occurring, so that there's no imbalance of growth of the head after you did the surgery. It's usually comprised of a compound or a resin called Surlyn that allows for that expansion over time. And then the other more common option in the later ages is called posterior vault remodeling. Just a brief overview of the procedure. You make zigzag incisions, and this is for a coronal suture, by the way, or a coronal craniosynostosis, but you dissect down on the ipsilateral transverse sinus, you remove the bone, and you make strips and what they're calling barrel stave osteotomies for the expansion. And I'll show a picture of those later on, but it's essentially making lines in the skull and allowing for them to adhere and make sure that the skull is, stable, but at the same time allowing for that expansion. And it's very beneficial in providing a great cosmetic outcome in comparison to endoscopic approaches and suturectomies. But, as I mentioned before, there is increased blood loss due to the hardening of the bone and the increased blood flow to them at that age. Increased operative time, anesthesia time always has to be considered. And since it's a more invasive procedure, you have increased rates of infection, dural tears, CSF leaks, air emboli, things like that. And it's also a very invasive procedure. You have to have a lot of experience to be able to complete this. So definitely comfortability with the technique will lead to more optimal cosmetic outcomes. And these are just some examples of some other procedures that are used to treat this condition as well. One is called distraction osteogenesis. It looks a little bit medieval, but it's actually been shown to have a really beneficial outcome in patients. And it really is designed to mimic kind of the gradual osteogenesis process and the natural expansion of the suture over time. But the problem is that when you have a person who has a synostosis, the bone that's being made there is already being made improperly. So you're expanding already poorly formed bone. And there is also a procedure that is required after the initial one to remove the distraction device. And operating twice on these babies, obviously you can increase the risk of infection, complications, things like that. So it's still used, but not as often as what I could see in the literature. And there have unfortunately been cases where if you have a family that doesn't follow up appropriately, they've left these devices in these children, and they've been found later on throughout the years and been absorbed into the skulls of these babies. So it's definitely not one for a family that you might not believe will follow up and adhere to the post-op recommendations. And this is just kind of a nice picture, of the techniques that are most commonly used. A and B are kind of the strip suturectomy that I mentioned about. C and E are the cranial vault reconstruction diagrams that you can see kind of have those lines. Those are the barrel stave osteotomies that are used to kind of design the skull to allow for expansion. And picture D is for the distraction osteogenesis device, and this is for the sagittal suture down the middle. But the concept is the exact same for a lambdoid suture. Okay, and then there's also a uncommon, I won't go too far into this one, but there's also a very uncommon presentation of lambdoid craniosynostosis that involves both lambdoid sutures and a little bit of the sagittal that creates kind of a Mercedes-Benz logo pattern. They call it the Mercedes-Benz pattern. And this one has a little bit more involved procedure that involves you going through the ventricles, opening up a bigger bone flap, and making similar barrel stave cuts into the skull, but is a little more involved in the reconstruction process. And then just a more recent article that came out of the group from Baylor talked about a technique called the sand dollar and staves technique. So the staves that we talked about earlier with the osteotomies, but they kind of do this one a little bit differently, in where they do the suturectomy and kind of the cranial vault reconstruction, where they create this kind of circle that is shaped like a sand dollar and doesn't cross patent suture lines. So you can see the zigzag cuts here in the first picture, and you can see the sand dollar staves that they cut into the skull to allow for better reconstruction. And they did a case series on these patients. They used it in 4. There weren't any post-op. And what was nice about this is it didn't cross the suture lines like many procedures do in cranial vault reconstruction, but allowed for single staging, which is important and decreases anesthesia time and morbidity around the procedure. So taking all this information in, our group wanted to find out what the most commonly utilized surgical intervention was, which ones provided the best outcomes, and any other trends in the data that we could find. So our group performed a systematic review. We used PubMed, Embase, and Scopus databases. 38 total articles met eligibility criteria, with case series being the most commonly mentioned article type. And in these 38 articles, there were about 430 patients. 268 of them had an isolated lambdoid craniosynostosis, 35 had bilateral, and unfortunately there was a large population that did not report if it was unilateral or if it was isolated or bilateral. We would like to assume that they were isolated, but we can't do that, unfortunately. Inclusion criteria for our systematic review made sure that all the articles were in English, full text was available. The patients needed to have an isolated or bilateral lambdoid craniosynostosis, and discuss management and patient outcomes for these children. We excluded any conference abstracts, letters to the editor, literature reviews, any articles that didn't include primary data on these patients, and no outcome management. And this is just a Prisma diagram that showed our process through the systematic review and how we came across and mentioned all 38 articles. So the results were a little bit not as complete as what we'd like, but I'll talk about that later. But the most common intervention utilized was the strip craniectomy, followed by the posterior vault remodeling, sand dollars and staves, and distraction osteogenesis were the most commonly used procedure types. In all the cohorts, approximately 70% had improved head contour, which is denoted by the visual analog scale, or VAS is what it's known as. Complication rate in the case series ranged anywhere from 0 to 20%, with a reoperation rate range anywhere from about 0 to 25%. Mean age at diagnosis of these patients was approximately 6.27 months. Mean age at surgery was about 11, and estimated blood loss was about 165 mLs. So finding and discussing these these results, the highest rate of reoperation, interestingly, and based on what we saw, was associated with open calvarial remodeling and tongue and groove osteotomies, which was just mentioned in one of the case series that we had, and was also was a smaller cohort as well. And we also learned that conditions that the patients had preoperatively played a larger role in the outcome as well. So we noticed that patients that had a torticollis prior to operation tended to have worse outcomes and residual facial asymmetry, even if the synostosis was surgically corrected. That could be due to the baby's preference for still wanting to turn on that side even after surgery. It could be just poor adherence to postoperative outcomes. We don't know, but this was a trend that we noticed. And then just some statistics and differences between the most commonly utilized techniques, where we separated suturectomy, craniectomy, and cranial vault reconstruction, or CVR. Mean times at diagnosis, they diagnosed the suturectomy patients earlier which makes sense, being that that's utilized more by the younger patient cohorts. Mean time and intervention was the result that we thought was the most interesting, as they operated on cranial vault reconstruction a little bit later than what we expected at almost 15 months old versus when it's commonly utilized between 6 to 12. Estimated blood loss was expected with a more invasive procedure being almost 300 mLs. And we found that more patients underwent the strip craniectomy versus the cranial vault reconstruction. And cranial vault reconstruction had a 10-time higher complication rate versus strip craniectomy. And then the cohort that we also analyzed was the distraction osteogenesis one, which had 47 patients. And this one surprisingly had only a 2% complication rate, which we thought was going to be a lot higher considering the increased attention needed to follow up, having multiple surgeries to remove it. So it was a nice and I guess interesting finding. Now, unfortunately, this systematic review and study had a lot of limitations to it. The volume of patients being one, there were only 433 patients. And of those 433, about 130 didn't identify which type of synostosis there was. So our statistics are a little biased. And there was also, we used the Robbins I tool to grade the bias of the articles in general. And we found that the overall risk of bias associated with these articles are high, meaning that the overall risk of bias with the statistical analyses is high as well. And that also has an interplay with the grade framework in having a lower overall study quality. And this can be contributed to by having only case series or retrospective studies and case reports as well. If we had maybe some randomized control trials in there, we would be able to provide stronger evidence. Also, we have to consider publication bias with our inclusion and exclusion criteria, meaning that we might have excluded some articles based on our criteria that would have fit other studies that could have contributed to the data better. And there was a lot of heterogeneity in how the data was reported in these outcomes. So we weren't able to do a true meta-analysis. And unfortunately, hopefully down the line, we'll be able to do one with more data. So in conclusion, this is a condition that is not commonly seen, but if someone enters neurosurgery, or even pediatrics, I believe that you'll see this at some point. And to kind of raise awareness of the need for a gold standard in the operative technique of this condition, there's going to be more multi-institutional collaboration needed to establish this. And taking away from this talk too, for med students, I guess, knowing the difference between, positional plagiocephaly versus a true lambdoid synostosis based on the physical attributes of the baby can really help and can potentially make sure that you get the child the proper care. And as you all, progress down your training, making sure that you're comfortable with the techniques that you're performing and being able to provide the best cosmetic outcome for these patients with this condition. So that concludes my talk. Thank you again for allowing me to come here and present. And if you have any questions, feel free to go ahead. Thank you.
Awesome. Great presentation, student Dr. Reardon. Did an amazing job. Just like he said, if anyone has any questions, feel free to either raise your hand on Zoom, or if you can't talk right now, throw it in the chat and I'll read it out. Dr. Johnston, do you have a question?
I do. Taylor, thank you for this presentation. I thought the quality of your presentation is excellent. You have great command of your slides. They're simple in terms of trying to understand it, and your pictorial presentations and the photographs that you provided give us good understanding of what the problem is. So I want to say thanks for that. My questions are twofold. First of all, relevant to the number of cases. There's a limited number of articles that have been reviewed, and equally low number of patients that have undergone some surgical procedures. My question to you is, and I think you admitted it, that there's no outcome management to look back and say, wow, this has made all the difference. And my question is to you on the outcomes, how do we have any information, idea, gut feeling of it's changing the infant's cognitive abilities? Do we have any lay of the land to say what their cognitive skills are going to be? Do we know?
Yeah, absolutely. And thank you for those comments. I greatly appreciate your kind words. I know that there is, and I can't remember where she's from. She's an excellent neuropsychiatrist, and she published this case series of all these children that have craniosynostoses, not specifically lambdoid, but she published all these papers that talk about those outcomes. And really the thing that made the biggest difference in reducing those poor neurocognitive outcomes was time to intervention.
Yeah.
But the problem is that, obviously wanting to intervene as early as possible is optimal. Sometimes the patients have comorbidities that don't allow them to be operated on at the time that is optimal to hinder those neurodevelopmental delays. So it's just an unfortunate balancing act between operating at X time versus waiting and making sure the child's healthy to do it, but also potentially causing further damage.
Longer you wait. Yeah. My other question to you is, where do you go to be operated? Are there centers that are there 2 or 3 or 5, or how many top centers are taking this task on? Name some operative centers that are referral basis. Are there any?
So there are, I know that a lot of the large university programs that have true pediatric neurosurgeons, there are some specialists in craniosynostosis. There's also, involvement with plastic surgery and oromaxillofacial surgeons as well. And kind of the interplay between those teams allow for the best cosmetic outcomes for these children. And that interplay is usually found at large places like, I know that the sand dollar and Staves technique was done at Baylor. I know that I did a rotation out at Geisinger in Danville, Pennsylvania, and they did some cranial vault reconstruction surgeries as well for children. So it's at large academic centers that have the resources to be able to have those specialists.
Thank you very, very much. I appreciate it. Nice job.
Thank you.
Dr. Gostowski, you have a question?
Oh, yes, thank you. I did put in the chat too. I know Texas Children's does this as well. So thank you, student Dr. Reardon. And for full disclosure, I am the Kansas City campus dean and an OMM specialist who has treated more children than I'd care to for torticollis and plagiocephaly. And I am not going to put you on the spot and ask you that question of would you do OMT, why or why not, or how. And I did want to bring to mind for our osteopathic students, I love that you had brought up the torticollis associated with plagiocephaly. I see a lot of that. And I do think there are opportunities if there are people in the area to do that work pre or even post surgically. I know some neurosurgeons would be hesitant, but post. I have only diagnosed one child with true craniosynostosis of the, it was coronal, it was unicoronal. And I really appreciate that you, and I think for all students and physicians, keeping the idea in mind of the difference between plagiocephaly and a true synostosis is huge, because to me it was quite obvious. I had a child who didn't present till he was about 6 months old in my office. Interestingly enough, had the torticollis treated, but the plagiocephaly didn't. And I was able to get the child into the helmet evaluation because they're the ones who are great at doing the measurements, and then proceed on, because it's also terrifying for the patient's family to even start thinking about this. So I really think it's great you brought this to people's awareness. We see it, it's unfortunate. There's no OMT in the world that could do it, but I was able to make enough changes, and the patient in this case did go on. It was really very nice presentation. Of course, I encourage all our osteopathic students to find somebody qualified in their area to do some pre-op work, at least for the rest of the structure for these patients, and do what we can. So again, great job, and best of luck to you in your future.
Yeah, thank you so much, Dr. Guskowski. I really appreciate that. And yeah, that would be a great integration to use OMT pre and post operatively. It'd be interesting to see if, even though the cohorts are incredibly small, it would be interesting to see if, isolate or just using all craniosynostosis patients and seeing, their outcomes are improved. You treat their torticollis or whatever comorbidities you can prior to that. And like you said, too, it's very, worrisome for the parents when you see their child's head is looking a little bit different, but it's nice to know, if it just requires a helmet for 3 months or, hey, they need surgery. This is legitimate. So just being able to provide them the best care they need is important. So, but thank you very much.
Awesome. Any other questions, comments? Well, if not, thank you so much again, student Dr. Reardon, and thank you everyone for being here today. Great questions, great discussions, and really great presentation. Thank you again.
Thank you so much.